Of all the extreme methods that psychiatry has used in its struggles to alleviate the suffering of the mentally afflicted, perhaps none is as gothic or as full of horror as lobotomy. How, we ask from our comfortable perspective in the 21st century with our psychopharmacies and our neurosciences, could something like this have come to pass? The inventor of the lobotomy was a neurologist from Portugal, Igaz Moniz. In 1935, he attended the Second International Congress of Neurology at London. There, he heard a talk given by Carlisle Jacobson and John Fulton from Yale about experiments they'd done on chimps. By ablating their prefrontal cortexes, they managed to turn highly aggressive and emotionally volatile animals into quiescent beasts. In effect, they had destroyed the chimp's affect. This got Moniz to thinking about the symptoms of schizophrenia and how it was often characterised by extreme and noisy emotional outbursts, occasionally accompanied by violence to self and others. And regardless of what he thought was the etiology of schizophrenia, he believed the symptoms of the condition might be mitigated by the use of a similar technique upon schizophrenic patients. Okay, let's take a pause there. You've got to be pretty desperate to go down this path. You've got to think that the condition is so intractable and that the lives of the patients are so degraded to believe that intentionally inflicting brain damage on a person is a good idea. But the seed of the idea had been sown, and Moniz returned to Lisbon with a plan. He wasn't a surgeon, so he needed a surgeon to carry out his new therapy. He recruited Almeida Lima, and between November 1935 and February 1936, a batch of patients were given the first lobotomies. It is a characteristic of our story that novel therapies claim great cure rates. You'll remember that that had happened as part of the cotton story. In the case of lobotomy, Moniz maintained that of the 20, 7 were cured, 7 had their symptoms ameliorated, while in 6 there was no change at all. By the standards of the day, if his figures were correct, lobotomy might not have been regarded as a miracle cure, but it certainly possessed huge potential for dealing with this previously untreated form of human alienation. Moniz pushed on to make the operation easier. He developed an instrument, the leucotome, examples of which can be seen at the museum and here. But to get evidence of how important his heroic operation was regarded by medicine and science, I offer as the first exhibit the award of the Nobel Prize for Physiology or Medicine in 1949, complete with glowing citation. 1949, 14 years after the first lobotomy, and it was still regarded as one of psychiatry's major breakthroughs. Frontal lobotomy, the Nobel Committee declaimed, despite certain limitations of the operative method, must be considered one of the most important discoveries ever made in psychiatric therapy, because through its use a great number of suffering people and total invalids had recovered and had been socially rehabilitated. Moniz's certain limitations of operative method had, however, already been dealt with by one Walter Freeman, who developed the quick and easy method of the transorbital lobotomy. Freeman had seen great potential in lobotomy. He had even modified Moniz's operation to make it easier to perform. But it was still pretty drastic, requiring trephining the skull on both sides before ablating the prefrontal cortex. It was a major operation requiring anaesthesis and lengthy periods of recovery. It occurred to him that if you could get to the cortex under the eye using something like an ice pick, the operation could be done quickly, effectively and safely. He honed his technique by practicing on cadavers, lifting their dead eyelids, inserting the pick above the orb and hitting home with his hammer to hone the technique. Of course, also checking the results with dissection after. The film that follows provides a detailed, graphic and disturbing account of transorbital lobotomy. If you're squeamish, You may want to fast forward 4 minutes ahead.
Turning now to the operation itself, very little preparation is necessary for transorbital lobotomy. This patient came to the hospital this morning after breakfast, and if all goes well, she will leave tomorrow afternoon. The operation can be done under any general anesthetic, but electroshock is preferred because of its familiarity to the psychiatrist. Transorbital lobotomy is performed during the stage of post-convulsive coma. The electrodes are applied and the first shock is given. The convulsion lasts about 40 seconds. When the patient shows signs of returning consciousness, a second convulsion is administered. Usually 3 successive convulsions are necessary, but in old people a single one may be sufficient, while in a sturdy young person 4 or even 6 convulsions may be administered without danger. Now that the convulsion has subsided, the nurse holds a towel over the nose and mouth of the patient. The operator lifts the upper eyelid, inserts the leucotome into the conjunctival sac, and aims it parallel with the bony ridge of the nose. He drives the point through the orbital plate, and at a depth of 5 centimeters, swings the handle far laterally. He then returns the instrument to a slightly oblique position, still parallel with the bony ridge of the nose, and drives it 2 centimeters further. Steadying the patient's head, he then moves the handle of the instrument about 20 degrees medially and 30 degrees laterally. In this latter position, he strongly elevates the handle of the instrument, often fracturing the orbital plate, and then finally returns the instrument to the parasagittal plane. The operation on the left side is seen from the profile view, which best illustrates the deep frontal cut. It will be noted that the instrument upon removal appears clear and shiny, but in view of its contact with the skin of the lower eyelid, different instruments are used for operation on the 2 sides. In this second patient, after operation, there is no damage visible.
It definitely did the trick in terms of speed, and soon Freeman was performing multiple operations a day. For some of those witnessing Freeman operating, it was much too much to the point. The physician Wolfhard Blaumgartel recalling, how can a man be that relaxed just going into the brain? Freeman performed the operation for the first time in 1946 and then spent the best part of 21 years promoting it throughout the hospitals and doctors' offices of the USA. By the time he'd stopped hammering his ice pick, he had personally performed more than 2,500 of the operations. Many others adopted the technique, and by 1951, upwards of 18,000 lobotomies had been performed in the US alone. Sometimes Freeman performed the operation electively, as in the celebrated case of Howard Dully, who was forced to undergo the treatment as a 12-year-old in 1960, despite the fact that it was apparent to all who examined him, bar Freeman, that there was nothing wrong with Dully whatsoever. Dully has come to symbolise the horror of the transorbital lobotomy, the real-life equivalent of the cuckoo's nest McMurphy, sacrificed on the altar of dehumanising psychiatry. And he's happy to bear witness to the abuse done to him. But he also represents something else, how ineffective the procedure could be. Dully is a warm, articulate individual who seems to have been unaffected by the procedure. Maybe brain plasticity played a part, but as Blaumgartel hinted, it was a hit-and-miss business that had no means of visualising the quantity or indeed quality of brain matter destroyed. What I think surprises many people in retrospect is the meekness of medicine in the face of this desperate remedy. Well, the reason for this is quite simple. Psychiatrists were desperate, and in general, as Jack Pressman indicates, it remained a treatment of last resort, except in Freeman's hands. Virtually every other therapeutic avenue had to be explored before taking this final drastic step. And in this, one should heed Pressman more than Wallenstein, whose readable account provides sensation over nuance.